everyone, thanks for joining us for our latest edition of Phoenix Children's Live. I'm Stacy Dillier, one of the brand managers here at Phoenix Children's, and today I am joined by Dr. Andrisevic and Dr. Belzer from our Center for Pediatric Orthopedics, and we are going to be talking about clubfoot. If you have any questions along the way, just ask them in the comment section, and Jenny from our marketing team will ask them aloud. So if you hear a voice, it's just Jenny. Don't be alarmed, and we'll get them answered. And if you have any questions after the live stream ends, just put them in the comment section, and we'll make sure that we get them over and answered for you. Okay? All right, let's jump right in. First question, what is clubfoot?
That is a great question. So clubfoot is a condition of the foot that starts in the intrauterine phase, and when the babies are born, the foot is in a different position.
Okay.
So the structures in the back of the ankle and foot are tight, and the structures on the inside of the arch are also tight.
Okay.
So the foot becomes down and in and contracted and difficult to obtain a nice position of the foot.
Okay, and so it's diagnosed, so parents know before their child is born that they're going to be born with clubfoot?
Sometimes that is true. Sometimes you can diagnose clubfoot on prenatal ultrasound.
Okay.
And people have seen as early as a 15-week ultrasound findings consistent with clubfoot. That is, of course, more accurate if that finding is seen on multiple ultrasounds.
Okay.
And if the quality of the technician, the quality of the ultrasound can all factor into that.
Okay, all right. How common is clubfoot?
I would like to say that clubfoot is the most common birth defect of the leg.
Okay.
And the incidence is variable depending on which part of the world you are in. But in North America, the incidence is about 1 to 2 per 1,000 live births. That means if 1,000 children are born, you can expect 1 or 2 to have clubfoot.
Okay.
So it's very common, and then so we see a lot of them. See about 60 new cases a year.
Oh wow. Okay, that is quite a few. What causes it? Do we know what causes clubfoot? Is it just the way they're positioned, stuff like that?
So what we know about clubfoot inheritance is kind of multifactorial at this point.
Mm-hmm.
We do see a familial occurrence in about a quarter of our patients, 25%.
Okay.
But that means the other 75% don't have any family history of clubfoot, and it's more of a spontaneous finding. Do you want to talk about kind of the genetics?
Sure.
The
so,
transcription factor?
When you say causes, it's multifactorial. It could be both like environmental as well as some genetic. But there's no single gene that's directly responsible for clubfoot, as opposed to, for example, Down syndrome, where you can say that there's a single gene, either abnormality, which you can identify. So it's not like that. So it's called as a polygenic condition, where multiple genes have kind of some influence on what happens. Okay, so they have identified, like Dr. Andrisevic said, about 25% run in families. So studies are currently ongoing to identify some genes which may predict like a severe case of clubfoot, or treatment maybe, or where the clubfoot may be recalcitrant to treatment. I think a couple of genes that have been identified is called, one of them is called as the PITX gene. When children have this gene, they have it's been identified in children who have deficient anterior and lateral compartment muscles in the leg, and it's been shown in a recent study in the Journal of Bone and Joint Surgery that children who have this gene and clubfoot are more likely to have recurrences, and the response to treatment is not as good.
Okay.
So that's something, but not every child has not in every child with clubfoot can we identify a gene that's responsible for it.
Okay. And you mentioned the family aspect. If one child is born with clubfoot, is another child more likely to have it, or not necessarily?
Mm-hmm. So if you have one child with clubfoot, the percentage that an additional child will have clubfoot is about 3%.
Okay.
So there's a 12 times kind of higher risk.
Okay.
I believe you can say. And then other causes could be, sometimes it could just be positional. That means the way the child was in the mother's womb. If there is decrease like amniotic fluid, or if there's multiple pregnancies, if there's a packaging abnormality, that means the mother's womb is small relative to the size of the baby. Sometimes you can have like a positional clubfoot, which usually resolves very soon, within a few weeks after the child is born. Other causes could be low. So the causes, we group them into idiopathic, where we don't know what the exact cause is, or we could group them into neuromuscular, where they could have neuromuscular conditions predisposing to clubfoot. For example, they could have like arthrogryposis, or various other, like spina bifida or myelomeniingocele, which is causing the clubfoot.
Okay.
But in idiopathic, there's no easily identifiable cause, so that's why it's called idiopathic. And then obviously there could be syndromic, where it's part of various syndromes. Like for example, one of the skeletal dysplasia is called diastrophic dysplasia, or it could be associated with fibular hemimelia or tibial hemimelia, those kind of conditions.
Okay.
So those are all syndromic. And then you have neuromuscular, like spina bifida, arthrogryposis, etc. And then you have the idiopathic, and then in idiopathic, most of them, about 95%, are called as typical club feet or typical idiopathic club feet, which is the most common type you see, and then about 3% are atypical club feet.
Okay.
And there are some findings on clinical examination that we look for when we examine the child first before starting treatment, to kind of differentiate the complex or atypical club feet from the typical regular club feet.
Okay.
Because the outcomes are a little bit different between the two groups.
Okay.
That's why it's important to delineate those groups before.
Okay, and of those three that you mentioned, the idiopathic, the neuromuscular, and the
Syndrome.
syndromic, do you see one? Do you see more patients in one of those categories?
The idiopathic.
Okay.
The other groups are less common.
Okay. Is there a certain population or ethnicity that seems to get clubfoot more than another?
For example, like in Polynesia, which is like New Zealand, where there is a big Maori population, they have like 7 times higher risk of clubfoot, and they are more recalcitrant to treatment, is what the published reports say. But the incidence is kind of more or less otherwise same in the rest of the world.
Okay.
But there are some pockets, special populations that have slightly higher risk.
Okay. All right. Good to know. All right. Does surgery cure clubfoot?
Well, I presume you're talking about the previous standard of care for the treatment of clubfoot, which used to be posteral medial release surgery, which was a fairly extensive surgery to obtain a nice position of the foot. And that was pretty much the standard of care as recent as 20 plus years ago, until the new Ponseti method really is now the gold standard of care. And we were seeing that the surgery was correcting the foot and getting into a beautiful position, but it did not cure it for 2 reasons. In the short term, you could still see recurrence of the clubfoot unless it was appropriately braced and followed. And then long term, 20, 30-year outcome studies reported that those feet who had more extensive surgery were stiffer feet, weaker feet, more painful feet. So more surgery equals worse outcome was really the take-home message from a 30-year outcome study we have in our Journal of Bone and Joint Surgery from Dr. Matt Dobbs out of St. Louis. Surgery definitely does not cure, and that's why we are fortunate that we have a much better way of treating clubfoot, which has shown much more favorable long-term outcomes.
Okay, so what is the Ponseti method, and what all does it entail?
So let me just clarify. So the surgery in posteromedial release, it involves joint invasive surgery. So there are 2 types of surgeries. One is surgery which does not get into the joints. That means we are not opening the joint capsule, and we're not damaging the articular or the joint cartilage, but staying outside, that just lengthening muscles, transferring muscles from one place. That's called extra-articular surgery. It means stays outside the joint.
Okay.
Those surgeries are not as bad, but surgeries which involve getting into the joint, releasing the capsule, and then inadvertently causing damage to the articular cartilage, those surgeries are more damaging to the foot in the long term.
Okay.
So the posteromedial release and complete subtalar release, which were the surgeries done previously, which involved extensive surgery exposing multiple joints in the foot, essentially taking apart the foot and then repositioning it. Like Dr. Andrisevic said, gives good results in the short term, but doesn't hold out in the long term at 10 or more years.
Okay.
And results deteriorate with time, resulting in only about 45% good results. That means only less than half of them have good results.
Okay.
As opposed to the current gold standard, which is the Ponseti method, which is about, in Ponseti's hands and in most people's hands around the world, provided they are paying attention to detail, are adequately trained in the Ponseti method, and then don't modify the method too much, and then stick to the rigid protocol that Ponseti had, then you can expect about 90 to 95% good results in the long term.
Okay.
About a third of them may need some fine-tuning surgery. That means surgery which does not get into the joint for muscle balancing and then fine-tuning, but otherwise the results are usually pretty good.
Okay.
So the Ponseti method, like you asked, is named after Ignacio Ponseti, who's a Spanish doctor who came over to the United States, initially to Mexico, and then to the United States, and then he started training here in 1948 in Iowa under Dr. Arthur Steindler, who's a professor there. And then by chance, Dr. Steindler asked him to look at the results of surgical treatment of clubfoot. And then when he looked at the results, they were kind of appalling. So he thought, he started thinking about how can we make it better. And then by chance discovered the casting method, which is named after him.
Okay.
So it involves essentially two phases.
Okay.
The first part of treatment involves serial casting. That means we put a series of casts once every week for about 4 to 6 weeks.
Oh, wow. Okay.
It's a long leg cast as shown in this
Somewhere
picture
like this.
here.
Okay.
For example, this is the first cast. As you can see, it's a long leg cast. This is an infant's foot with a cast on. It's a cast model. And then we gradually change the cast weekly, essentially bringing the foot, gradually turning it out from a position which was down and in to a position which is up and out. Gradually, the only thing you can't correct with this is the tightness of the heel cord, which gives rise to like an equinus or an ankle pointing down position. So that's called as the casting phase. And then when the rest of the foot is corrected, then we just do a small surgery, which is called as a tenotomy. That means we cut the heel cord through a very small percutaneous incision, and then we lengthen the heel cord, and that allows us to bring the ankle up. And then after that, there's one more cast, which is for 3 weeks.
Okay.
And that completes the casting part of the treatment.
Okay.
This is the period when the surgeon or the doctor does all the work to correct the deformity.
Okay.
And then at the end of this period, in most typical club feet, the correction is complete.
Okay.
That means the ankle goes up to about 10 degrees past neutral, and then the foot is abducted in relation to the thigh about 60 to 70 degrees.
Okay.
We overcorrect it so that it doesn't come back. The risk of recurrence is reduced, is
Okay.
what Ponseti found over
Okay.
a period of time from 1948 onwards.
Okay.
So that's why we kind of overcorrect it to start with. So the parents ask, why do you have to, foot was turned in, now you're turning it out.
Okay, that makes
This guy crazy is what they ask. So, but this is to tell them that we purposefully do it so that to reduce the risk of it recurrence or recurring or coming back.
Okay. So how many total casts does a patient get?
Like I said, approximately anywhere from 4 to 8 casts.
Okay.
It depends on the severity of the foot. So
Okay.
it's a spectrum. The condition, it's not like every child is the same
The
thing.
Okay.
So it's some are mild, some are moderate, some are severe in terms of the clubfoot deformity, and also how the tissues are to feel. I mean, some are more flexible, some are more rigid.
Okay.
So we have a couple of classification systems that we use to assess the severity of the clubfoot, and based on that, we decide, and also based on the response to the casting that we decide. So So as many casts as needed to correct the foot is the answer.
Okay.
But usually it's around 4 to 8
4 to 8.
casts.
Okay, perfect. I think we had a question come in, so Jenny, shoot.
Does clubfoot affect calf muscles? I have bilateral clubfoot in addition to a very small circumference of my calf and shins.
Yeah, I think it's a very good question. It does affect, it's a field defect. It's not just a problem of the foot.
Okay.
It's a problem of the muscles of the leg itself.
Okay.
So both the leg is also smaller in girth, as well as sometimes, most of the time, shorter as well, a little bit.
Okay.
So when fully grown, the foot size may be about a size to size and a half smaller.
Okay.
The leg size, the girth of the muscles is smaller, and then the length of the leg is also about a centimeter and a half shorter.
Okay.
So if it's bilateral, sometimes it's good because you don't notice the difference between the two sides, and you can wear shoes of the same size. If it's unilateral, then you have to look for shoes of different size, and it's more
Okay.
noticeable.
Okay. So can a certain, like your left leg, have a different degree than your right leg?
Yes.
Okay.
Yeah, and also one side could be typical, other side could be atypical.
Oh, okay.
Though that's less common, but it can be. One side is more severe than the other.
Okay, so have you ever seen where one leg may need 6 casts and the other leg just
Mhm.
needs 4 casts?
Yeah.
Oh, okay.
Then we just, once the other leg is corrected, we just hold it in that position
Okay.
while we complete correction on the other side.
Okay.
Yeah.
That's good to
And
know.
I just wanted to pick up, you talked about the Ponseti method being the first phase is the
Right.
casting correction.
Mhm.
And that's where the physician is doing most of the correction and the deformity correction. But then the second phase,
Yes.
which is equally as important,
Maybe more important.
maybe more important, is bracing.
Okay.
So that is
That's
extremely
what we have.
important. And we did bring 2 examples of the most commonly prescribed braces for club feet. This is just a straight bar. This is Dr. Ponseti's trademarked bar. So the sandals kids wear are all the same. So this is a Ponseti bar. It just clicks in. You can set this at different degrees of rotation for the surgeon's preference for the clinical situation. And then this is called a Dobbs bar. This was created by Dr. Dobbs at Washington University, who's another big researcher in clubfoot. And this one is a little more expensive, but it does give you a little bit of independent motion between the 2 feet.
Okay.
So generally we usually start with the Ponseti bar because of the price differential, and most patients tolerate that very well.
Okay.
But if there's a certain reason that a patient needs this, or if they, for whatever reason, didn't tolerate the first brace, then we'll go up to the Dobbs bar.
Okay. And how long are they usually in the brace for?
I'll just add a couple things. So, in addition, biomechanical studies have shown that the Ponseti shoes and the fixed bar is more effective because we need a force which is directed up and out to maintain the position of the foot, as opposed to a bar which allows some degree of movement between the 2 feet. So at least in biomechanical situation in the lab, the Ponseti shoes and the fixed bar or the Dennis Brown bar is still more effective and is recommended by the Ponseti International Association. The Dobbs bar is the next choice, but they haven't been trialed. Like, we need a huge population to study because the difference is very minor in outcomes. So because of that, in order to show a difference between the two, you would need a huge multi-center trial, which is very expensive, and that's where it hasn't been done yet. So that's what we would recommend, and usually the treatment we would say is full-time for about 3 to 4 months after the casting period is
Okay.
done. So when the child comes out of the cast, the same day they go into the brace.
Okay.
It takes them a few days of weaning in period to tolerate about 23 hours.
Okay.
But usually we would recommend 23 hours a day. Full time is 1 hour to give the child a bath, do some exercises, and then that's for about 3 to 4 months. I usually go for 4 months,
Okay.
and then after that is part-time bracing, which is in the night and nap time for about 16, starting with about 18 hours and then decreasing as the child gets older.
Okay.
And that goes up until the age of 2 to 4 years old.
Oh, wow.
So again, there's no science whether it should be 2 or 4. Currently, I think there's a multi-center study which is going on to see if the shorter period of bracing is equally effective as opposed to 4 years. But as of now, 4 years is the current gold standard.
Okay. And when you're 4, how long do you usually have them wear the braces? How many hours a day? I mean, can they walk when they're in these braces?
When you're using it night and nap time, they're usually fine during the daytime
Okay.
walking without them.
Okay.
And then at night time they use the brace.
Okay.
After 4 years, why use it for 4 years? Because the foot grows maximum in the first 5 to 6 years.
Okay.
Almost 75% of the foot is grown by the age of 6.
Okay.
And the fastest period of growth is the first 4. And that's why.
Okay.
And then by that time, family is usually at the end of their tether.
Okay.
And then we kind of start using the brace after that.
Okay.
But most of the recurrences, if you look at the studies, they happen, most of the 90% of recurrences happen before the age of 4.
Gotcha.
And only about 10% after the age of 4.
Okay.
But they can still recur after the age of 4.
Okay. And if they reoccur, do you have to start back with phase 1 with the brace or the casting?
I think it depends. We have to
Okay.
re-evaluate the child, but then we use a number of things to deal with that, starting with the casting,
Okay.
and then maybe surgery, maybe some continuing bracing, things like
Okay.
that. Yeah.
Okay.
The bracing can't be stressed enough. I mean, they did a study looking at brace compliance
Mhm.
and recurrence of clubfoot. And if you're not compliant with the bracing, there's almost a 90% recurrence rate of some or all part of the deformity, versus the compliant patient's 6 to 8% recurrence
wow.
rate.
Okay. So wear the braces. Keep the braces
Maybe
on.
the recurrence rate is maybe slightly higher than that. I would probably say about 25 to 30%. But like I said, everybody is stressing nowadays that the success of Panseri treatment depends on the success of the family in being compliant with the brace.
Okay.
Full stop. Okay, if that doesn't happen, then it's going to recur.
Okay. And how early after a patient is diagnosed do you usually start the phase 1 casting? How old does the patient have to be before you start the casting?
So, an ideal scenario, if your baby does have clubfoot, we would pick that up on prenatal ultrasound,
Okay.
and then we'd actually see you for a prenatal consultation, just to meet the provider, meet the resources in clinic, just get a whole feel of what your Panseri treatment would look like, and make sure you're comfortable, because you're going to be spending a lot of time with that provider. And then after the baby's born, safe delivery, healthy mommy, healthy baby, and then you settle in at home, and then you give us a call pretty soon after you get home from the hospital.
Okay.
And ideally, we'd see you, 7 to 14 days
Okay.
of age.
Okay. Do you have anything to add to that, Dr. Balzer?
Well, a couple of things. One is if the ultrasound shows in the antenatal period, a 20-week scan, if it's showing clubfoot, then we have the Arizona Fetal Care network here, and the obstetricians can refer the patient and the family in for a prenatal consult
Okay.
if they want more information. So Jessica Feltz is the coordinator for that, and we can send you details. They should be available on
Yes,
our
they're on the
website.
website. We'll post it in
Yeah.
the comments.
And then she could set you up with us, one of us, to do that. And then the second thing is, once the child is born, because the expected date of delivery, usually the child is born only 5% of the time. So it's variable, so we can't really make an appointment before.
Okay.
But after the child is born, the mother is bonding with the child, but the father or other family members can make the appointment on the day or a couple of days later.
Okay.
Usually we allow 2-3 weeks for bonding, and then we can start treatment after that.
Okay.
But we can also treat the child up to the age of, people have been using Panseri technique even when they are adults, up to the age of 40 years.
Okay.
But as the child grows and becomes an adult, it becomes less, the body is a viscoelastic structure, so the water content is more in the tissues when the child is young.
Okay.
So we get better correction and easier correction when the child is young. So the younger we start the treatment is better, but equally we can correct it actually anytime.
Okay.
I have done children 14, 15, like in India and other countries, and
Okay.
we can still get the correction. We may not get 100% corrected, but like I said, we can still get it corrected pretty
Okay.
good.
And what happens if it goes untreated?
Well, untreated, like I said, I have seen patients
Mhm.
anywhere from birth to like 70 years or more with club feet. So it doesn't correct by itself. True clubfoot doesn't correct by itself. And it, like I said, as the child grows, because of the muscle imbalance, the deformity can get a little bit worse. in some patients or in most patients, and then it won't stop them from walking, but makes it difficult to walk.
Okay.
Makes it difficult to wear regular shoes. Makes it difficult to walk on uneven surfaces, for example, in rural areas, or makes it difficult to play sports. And then as the bones get deformed, as they grow older, arthritis sets in, and it becomes painful. So for all those reasons, and it's a significant social stigma, and it's at least in India where I've seen many of these. Women can't get married. Men can't. If somebody has a clubfoot, they won't employ them. Like in some jobs, they have to do a sedentary job because they can't walk for long distances. So for all those reasons, they constitute a significant economic burden on the society. So for all those reasons, if we can correct the clubfoot, which is easily done with the Panseri technique, they'll be functioning as normal individuals in the society and contributing, greatly to this to the society.
Okay.
So that's why we would recommend treating it.
Okay. And you mentioned sports. If clubfoot is corrected, are kids still able to play sports as they get older, or is there any issues there?
Yeah, our goal for a properly treated clubfoot is to have a neutral plantigrade foot that is painless, that you can wear regular shoes in.
Okay.
And that includes recreational activities.
Okay.
I mean, I think everybody knows from the blogosphere and from the web, when you Google clubfoot, that some very famous athletes did have clubfoot and were treated properly for that. Troy Aikman was a Dallas Cowboys quarterback. Christy Yamaguchi won a gold medal in figure skating. Wow. And Mia Hamm, a soccer player. So they all had clubfoot.
I had no idea.
I think what are long-term studies, not ours, but done in Iowa, 30 years and 50 years have shown is that they can do almost anything, even though the correction may not be 100%.
Okay.
On X-rays and things like that, they can still, and even if they have some minor residual deformities, as long as you maintain the range of motion of the foot, then they function very well.
Okay.
And they may not be able to do like manual laboring and that kind of job as well, maybe a little bit less well than normal people,
Okay.
but otherwise everything else they can do as well.
Okay. So why Phoenix Children's? What makes our program, our Center for Pediatrics, unique? Why is it important for children to be treated by pediatric specialists for clubfoot?
Well, I think for a number of reasons, like knowledge, attitude, skills, I can say. So knowledge-wise, I think we are both fellowship trained, and we've had special training in Panseri method. I've trained with Dr. Panseri myself in Iowa, and with Dr. Jose Marquende. I am approved by the Panseri International Association. I'm actually a faculty trainer for the Panseri International Association, and I do teach Panseri method both locally and sometimes like in other places. And then so has Dr. Andrisa been trained specially during her fellowship, and I'll allow her to speak for that. Okay. And then the other reasons, that's knowledge. And then not only we have knowledge of the Panseri method, but also how to treat complications and sequelae, both during the infantile period and later, and also like untreated clubfoot. So we can treat the whole spectrum of clubfoot problems, okay? And then in terms of attitude, we have the right attitude. We want to do the best for our kids, treat them like our own children, and then and we try to communicate as well, or would like to communicate, very well with our families, work like a team with the family. So that's as far as attitude is concerned. And in terms of skills, like I said, we are both very well knowledgeable as well as have the skills, both the casting and the surgical skills to take care of the whole spectrum of clubfoot deformity.
Okay.
And for all those reasons, and also we have good support in terms of the fetal care network. We work with, if they have complex syndromic clubfoot, we have other specialists here because it's a tertiary referral hospital. We have all the people in the right place to help. We have the right team in place to help us take care of more or less almost anything that these children may need. And I think for all those reasons, and we see a lot of these clubfoot. We have, like I said, I myself see about 60 new clubfoot, and I probably have more than like 500, 600 patients that follow up with me.
Wow.
And then I let Dr. Anderson talk.
Well, I can't say I've counted my numbers. I just did 5 clubfoot casts before this session. But yeah, I trained with a true disciple of Dr. Panseri himself. So I agree with everything you've said about the reasons to come to PCH for clubfoot treatment.
Great. I wouldn't go anywhere else if I had a kiddo who needed care. Last question I have, do patients need to be referred? So are they usually referred, after they give birth to their child, are they referred from that hospital that they gave birth at, or can they just call up our Center for Pediatric Orthopedics and say, hey, my child was born with clubfoot, can I schedule an appointment?
It really depends on your insurance.
Okay.
Most insurances require a referral to a subspecialty provider. Your pediatrician in the newborn nursery or your post-discharge pediatrician would be happy to give those referrals.
Okay. Perfect.
And we expedite you getting that first appointment. We save slots in our clinic schedule for new clubfoot evaluations.
But if the families have any problems getting in to see us, they can call our office, the number is 602-933-3033, or they could call our Arizona Fetal Care Network coordinator, Jessica Felds, and we kind of work with families to, even if they don't have insurance or if they can't pay, we're still happy to see them. And then we'll work out something with the family.
Okay.
But our aim is to treat like every child in Arizona with club feet and give them the best results that they would probably have if they visited Dr. Ponseti or if they visited Iowa.
Okay. Perfect. Well, is there anything else that we didn't talk about that you wanted to touch on, or I think we covered?
I think I would just say do some research before you decide where to go for the treatment.
Okay. Perfect. Thank you both for joining us. It was great to have you. Loved having this here to see. Very knowledgeable for me, so thank you. If you have any questions, just leave them in the comment section, and we'll be sure to get them over and answered. And tune in next Monday, November 27th at noon for our next Facebook Live. It's going to be on palliative care with Dr. Shaw. Thanks so much. Have a wonderful Thanksgiving.